This is the Pick Your Poison podcast. I'm your host, Dr. JP, and I'm here to share my passion for poisons in this interactive show. Will our patients survive this podcast? It's up to you and the choices you make. Our episode today is called Pumped. Want to know what eating meat has to do with doping and drug testing in the Olympics? What medicine used to treat asthma in horses is abused by humans for weight loss? Today's episode starts in the park. On the way to your shift, you've stopped into the residency picnic, a potluck celebrating the end of the year. You drop off several pies and grab a hot dog. Your favorite intern introduces you to her boyfriend, a big muscular guy. You've heard the other residents say he's a bodybuilder. You finish your hot dog and walk towards the gates to exit the park. The two of them are sitting on a bench. He's breathing heavily and sweating profusely despite the mild weather. You raise an eyebrow. She's worked with you long enough to know it means, what the heck is going on here? He's having chest pain, she says. He waves a hand to disagree, but instead clutches his chest. I think we need to go to the ER, she says uncertainly, not the way any EM intern wants to spend the day off. Her boyfriend is a fit, muscular 25-year-old man with chest pain. The likelihood this chest pain is really an emergency? Pretty low. The risk of a heart attack or an acute coronary syndrome is less than 1%. But he doesn't look good. Maybe it's a collapsed lung or less emergent but still painful pericarditis, which is inflammation of the lining around the heart. A pulmonary embolus is possible, a blood clot in the lungs if he has certain risk factors. You nod in agreement. He should be seen. The hospital is only a few minutes away, so you hail a cab for the three of you. On the way, the intern gives you the history. She says her boyfriend has no medical problems and doesn't take any medicines. Walking around the park, he developed chest pain. It improved after sitting down, and they thought maybe it was indigestion. When he got up to walk back to the party, the chest pain returned, extremely severe this time. He also had shortness of breath, nausea, and was sweating copiously. He tried sitting down again, but this time it didn't improve. In the emergency department, you grab your white coat and log into the computer, waiting for the nurses to triage him. Sitting on the stretcher, he's still diaphoretic and rubbing his chest. He's still having chest pain. On the monitor, his temperature is 98.5 or 36.9 Celsius. His heart rate is 130 beats per minute. That's pretty fast, with a blood pressure of 105/65. That's normal, but it's pretty low for a big guy like him. His respiratory rate is 18, and his oxygen saturation is 100% on room air. You examine him, noting a normal mental status, normal breath sounds bilaterally, and other than the rapid heart rate, a normal cardiac exam. His extremity strength is good. He doesn't have any edema. He is very shaky and tremulous, but otherwise his exam is normal. You ask him some more questions. This isn't the first episode of chest pain. He reports 2 others over the past week, though he says they were mild and self-limited. He says he's had generalized weakness, which he thought maybe was from fatigue after he ramped up his workout routine. He hasn't had cough or flu symptoms, no calf pain or swelling, and no recent history of immobilization or long trips. You ask about a family history of heart disease. He says no and denies any history of clotting disease in himself or family members. The tech rips the EKG off from the machine and hands it to you. You frown. The intern looks over your shoulder, exclaiming, "What?" The monitor beeps as the patient's heart rate shoots up. She struggles to compose the surprised look on her face into her calm doctor's face. What's on the EKG? When we read an EKG, we look at a bunch of different things. First, the rhythm to see if it's normal or a dysrhythmia. Then the intervals, like the QTC interval we've discussed before, checking for evidence of certain toxins, as well as predicting the risk of developing a dysrhythmia. And of course, we check for signs of a heart attack or cardiac ischemia. Our patient's EKG shows sinus tachycardia, a basic fast heart rate, not an arrhythmia, which is good. It also shows ST segment depression, which is not good. One of the causes of ST depression is cardiac ischemia, meaning the heart isn't getting enough blood flow. His EKG doesn't show an actual heart attack, but if we don't handle this correctly, it could progress. What now? He's sweating more profusely. His eyes don't leave his girlfriend's very worried face. Is this an actual cardiac issue, or is something else putting strain on the heart? We need information because this is far from a definitive diagnosis. We need a chest x-ray to rule out a pneumothorax, i.e. a collapsed lung and other pulmonary issues. We need labs including troponin, a marker of cardiac disease. The troponin is a protein that's supposed to be found inside heart muscle. If we can measure it in the bloodstream, it's because it leaked out from a damaged heart. Pulmonary embolus, or PE, is still on the table. Severe cases do strain the heart. He doesn't have any risk factors for PE, though, like surgery, immobilization, family history, etc., but a rapid heart rate and chest pain are signs, so I'd send a D-dimer, another blood test, which, if negative, rules it out. You call the x-ray tech, and the nurse gets the labs. In the meantime, what should we do? He's sitting there clutching his chest and still sweating. Question number 1. What medicine should we give? A, aspirin, B, nitroglycerin, C, morphine, or D, all of the above? The answer is D, all of the above. We need to get rid of the chest pain. It doesn't matter how. What matters is that it stops. I'd also order IV fluids to see if that helps the tachycardia. And we should repeat the EKG in 10 minutes to make sure it hasn't progressed to a full-on heart attack. You get all those things underway, and then you ask him some more questions. You ask your resident to step out for a minute to screen for drugs of abuse. If somebody under 40 has cardiovascular disease like ischemia, heart attack, or stroke, a very common culprit is sympathomimetics like cocaine and methamphetamine. He says he uses occasional marijuana, but nothing else. Is this marijuana? No. Marijuana does increase the risk of heart disease, and evidence on that front is increasing, but it's doubtful with occasional use and really not likely in a 20-year-old. Is he lying about other drugs? I mean, maybe he doesn't want his girlfriend to know. We've seen that he's tachycardic and sweating. Both of those are elements of the sympathomimetic toxidrome. That said, I doubt it's cocaine or similar because he should have hypertension, not this relatively low blood pressure. The picture certainly doesn't fit with opioid overdose or hallucinogens. So no, I don't think his symptoms are due to a typical drug of abuse. You ask him what he does for a living, considering an occupational exposure. He says he's a bodybuilder, and your intern says proudly that he's recently gotten enough sponsorship to quit his day job. Question number 2. What drugs are commonly used by bodybuilders? A, anabolic steroids, B, caffeine, C, diuretics, D, creatine, E, all of the above. The answer is E, all of the above. Knowing he's a bodybuilder honestly opens Pandora's box all the way up when it comes to toxicology. Bodybuilders use tons of substances, legal and illegal, over-the-counter, prescription, supported by research, to purely speculative or outright disproven, to improve everything from weight to muscle mass to sleep to blood sugar and everything in between. Anything is possible here, but let's start with common categories. You don't need me to tell you steroids would be at the top of any list. They can cause things like liver failure and mood swings. They can accelerate cardiovascular disease, but it's unlikely at the age of 25. Human growth hormone is another common one. This causes side effects of joint pain, leg swelling, and diabetes. Interestingly, it causes carpal tunnel syndrome. Bodybuilders take insulin, even if they're not diabetic, to build muscle and regulate blood glucose. Amphetamines cause sympathomimetic syndromes, which we've already ruled out. Diuretics, i.e. water pills, are also commonly used. This is to reduce weight, to look leaner, and also, interestingly, to try to cover up performance-enhancing drugs in a urine test. So certainly, if he were dehydrated, he'd have a low blood pressure and a fast heart rate. But cardiac ischemia is kind of a stretch. Caffeine is another common substance, especially in your regular over-the-counter workout supplements. It does cause tachycardia, as I'm sure you know from having a large coffee, but it increases blood pressure, so again, it doesn't quite fit here. Creatine is really widely used. You may have taken it yourself, but it doesn't have much in the way of side effects. Occasionally, it causes kidney issues, but only in the setting of pre-existing problems. The patient denies steroids and says he does take workout supplements. Just as you start to ask more, you're called into a bad trauma, a pedestrian struck by a car. After you finish taking care of the critically ill patient, you return to your desk, noting the bodybuilder's lab results are back. His blood sugar is a little high at 300 milligrams per deciliter or 16 millimoles per liter. Of course, we don't do fasting glucoses in the ED, so it's hard to know what to make of that. It could be something abnormal, or maybe he just ate a slice of your pie at the potluck. His potassium, though, is notably low. It's 2.5 millimoles per liter, which is unusual in an otherwise healthy person. Low potassium causes muscle weakness, explaining at least that part of his history. Your phone rings, it's the lab with a critical result. His troponin is elevated and in the range of a heart attack. Uh-oh. We classify heart attacks into 2 general types. STEMIs, or ST segment elevation myocardial infarctions. Those are diagnosed on EKG. These patients typically go straight to the cardiac catheterization for a stent to open the blocked coronary vessels. And then NSTEMIs, which are non-ST elevation MIs, and these are diagnosed by elevated troponins on blood work. So our patient is having an NSTEMI. What is causing this heart attack in our 25-year-old bodybuilder? Back at his bedside, you deliver the bad news. You ask about non-prescription drugs and supplements. He admits to using creatine, caffeine, vitamins, and taking a lot of protein shakes. Well, none of these are causing a heart attack. You ask about other substances, and for a few minutes, all he says is, well... Your intern crosses her arms, glares at him, and says, "You better tell us the truth unless you want this to be the end." Well, maybe or maybe not true, but you don't contradict her because you do need the truth to treat him appropriately. He admits to using one other substance, and the low potassium here, I'll give you a hint, is a big clue. Question number 3. It's time to pick your poison. This is a very interesting toxin, but not a common one, so this is a tough question. If you're a layperson, no shame if you guess wrong. Is it A, thyroid hormone, B, clenbuterol, C, alcohol causing alcohol withdrawal, or D, aspirin? The answer is B. This is clenbuterol toxicity. And if you've never heard of this drug, don't worry because we're going to discuss it in more detail. But first, let me just say a word about the wrong answers. If you guessed thyroid hormone, I'm giving you half credit because it does cause tachycardia and it is used by bodybuilders to lose weight and speed up metabolism. However, it doesn't really cause low potassium or cardiac ischemia. Alcohol withdrawal would be nice here. He's got a high heart rate and tremulousness, but he should have hypertension. And unlike alcohol itself, withdrawal isn't typically associated with cardiovascular disease. Aspirin causes rapid breathing and acidosis, so it doesn't really fit. Back to clenbuterol. As I said, you may not have heard of it, but I bet you know what albuterol is. This is the medicine in asthma, rescue inhalers, and breathing treatments. So if you've ever seen anybody with asthma take a few puffs on their inhaler, you've seen albuterol. We use it like water in the emergency department for wheezing from asthma, bronchitis, and COPD exacerbations. It's very safe, but it does have some side effects, making patients tachycardic, anxious, shaky, and tremulous, just like our patient. Clenbuterol is in the same class as albuterol. Both of them are considered beta agonists. Back to this in a minute. Albuterol is short-acting, and via inhalation it works in minutes and it lasts maybe a few hours. Clenbuterol is ingested as a pill or a liquid with a peak effect in 2 to 4 hours and a much longer duration of action, anywhere from 24 to 48 hours, with even some reports suggesting it lasted as long as 72 hours. Clenbuterol isn't approved for use in humans in the US, only for horses with wheezing, though it is used in humans in the EU. It's not hard to get a hold of, and it's abused by bodybuilders to build muscle mass and also by people who want to lose weight. The typical side effects, same as albuterol, are tachycardia, anxiety, shakiness, and low potassium. We didn't discuss his other lab tests, but an elevated lactate is another clue to the diagnosis here. In addition to these effects, clenbuterol can cause a lot of other problems. Part of this is probably dose-related because bodybuilders aren't taking regular therapeutic doses, but they're taking 5 to 10 times the recommended amounts. Clenbuterol has caused heart attacks and ischemia in otherwise young, healthy people, including a patient as young as 17. Yikes. It can cause seizures, arrhythmias, psychosis, and rhabdomyolysis, which is muscle breakdown. Clenbuterol is a performance-enhancing drug, and it's banned in the Olympics and by WADA, the World Anti-Doping Agency. So question number 4. Athletes have blamed positive clenbuterol tests on exposure to contaminants in which of the following? A, water, B, meat, C, kisses, or D, albuterol inhalers? The answer is B. Athletes have blamed exposure to banned substances on a lot of things, including, honestly, kisses. But clenbuterol has been blamed on contaminated meat. It's really interesting because it's the reason athletes are often advised to avoid eating meat before competition in certain countries. The US in 1991 and the EU in 1996 banned clenbuterol use in livestock after outbreaks of poisoning where hundreds of people developed toxicity after eating the meat. Pigs and cows were fed clenbuterol to increase muscle mass, inadvertently poisoning the humans. And patients developed tachycardia, agitation, and low potassium. Several athletes who tested positive for clenbuterol subsequently blamed contaminated meat, including Alberto Contador, who was stripped of the 2010 Tour de France title after a positive drug test. These cases are always really controversial because clenbuterol can be in meat in very low quantities in some countries, but it is also definitely abused as a performance-enhancing drug. Before the 2012 Olympics, apparently Chinese athletes were advised not to eat any meat to avoid potential cross-contamination and positive tests. It's not just athletes. Clenbuterol toxicity has occurred also after exposure to contaminated heroin and cocaine. What does clenbuterol do? Well, as I said, it's a beta agonist, so it stimulates beta receptors. In the lungs, beta-1 receptors cause bronchodilation, opening up the lung passages and helping the breathing in patients with asthma or COPD. B2 receptor stimulation in muscles increases the strength of contractions and increases muscle growth. B3 receptors in fat cause lipolysis or fat breakdown. And activation of B2 receptors, interestingly, also drives potassium inside cells. So much so that we use albuterol in the hospital to treat high potassium, which is a life-threatening problem. Albuterol is powerful enough for an emergency to drive potassium into the cells and cause a lower potassium. So you can imagine how much clenbuterol can affect potassium, especially if you're regularly taking supertherapeutic doses. Back to our patient. Now we know what's happening, so what do we do to treat him? Well, we have two issues. We have a heart attack and we have clenbuterol toxicity. First, the heart attack. We've given aspirin and nitro already, fortunately. The good news, he says the chest pain is resolved and he's no longer sweating. A repeat EKG shows normalization in the ST segments. You consult cardiology. They agree with conservative management for now, including monitoring his symptoms and his troponins. Okay, good. Now on to the clenbuterol itself. Is there an antidote? That's question number 5. A, true. B, false. The answer is B, false. Technically, there's no antidote, but we do have medicines that can treat it. I said it earlier, it's a beta agonist, and we've talked in this podcast about medicines called beta blockers, right? We have lots of beta blockers. They're typically used as blood pressure medicines, metoprolol being a common one. I think you could choose any of these beta blockers, oral or intravenous, but in his case, since he's having ischemia, I'd go with something like esmolol, which is given as a continuous infusion. The other class of drugs you can consider is every toxicologist's favorite class, benzodiazepines. These are sedatives and will help him feel less anxious and jittery. Oh, and I almost forgot to mention potassium supplementation. I'd definitely replete his potassium before it gets any lower. Can you test for clenbuterol? Yes, but as usual, you can't test for it in a timely fashion. It'll probably take a week or so. So even if he hadn't been honest with us, which honestly happens frequently, the symptoms of tachycardia, low blood pressure, and low potassium are fairly diagnostic once you rule out other causes. You admit him to the step-down unit to continue titration of the esmolol drip and monitoring of his troponins. The history of performance-enhancing drugs and doping is a long and extremely fascinating one. It's enough for a whole podcast series. I really love hearing talks at conferences by WADA toxicologists. According to some sources, the word doping comes from a Dutch word, dop, which is an alcoholic beverage, which reportedly was consumed by the Zulus. Interest in performance-enhancing compounds is recorded as far back as ancient Greece, when a win in the Olympics was attributed to a diet of dried figs. Since then, just about anything you can think of has been used, including alcohol, hallucinogens, animal hearts, animal testicles, wine, cocaine, heroin, opium, and even strychnine. Back to our patient. His troponins rise over several hours but plateau the following day. He has no further symptoms and is discharged uneventfully. Your intern, now officially a resident, says he's promised her not to do any more performance enhancers other than things like caffeine and creatine. He plans to transition to social media and YouTube exercise videos to avoid the unhealthy standards of bodybuilding competitions. This is a fictional case, as are all our cases, to protect the innocent, but it is based on real poisonings. The last question in today's podcast is a pop quiz. Do you remember what substance used by bodybuilders is also used to manufacture explosives? Is it A, amphetamines, B, steroids, C, dinitrophenol, D, salicylates like aspirin? Listen to the Explosive Heat episode or follow the Twitter and Instagram feeds, both at PickPoison1 for the answer. Remember, never try anything on this podcast at home or anywhere else. Thanks for listening. It helps if you subscribe, leave reviews, and/or tell your friends. Transcripts are available at pickpoison.com. While I'm a real doctor, this podcast is fictional, meant for entertainment and educational purposes, not medical advice. If you have a medical problem, please see your primary care practitioner. Thank you. Until next time, take care and stay safe.